Exactly. I've been here too long. Don't get support by your own hospital system. Did you test that? Does it work? So you got that pointer, you've got this one, but that's got the advancer. Can you guys hear me? I know it's shaking one head up there. I will apologize in advance if we don't have grand rounds next week. It was going to be a multidisciplinary case presentation, and the multidisciplines couldn't get their act together to coordinate. So unless we can find another speaker, potentially Dr. Cigaroa, although he's incommunicado at this time to ask him, we may have to postpone next week's grand rounds. Today, we'd like to welcome back Dr. Luci Leykum. She has presented at this forum in the past, I believe, chaos theory. Yes, I remember chaos, because it surrounds me all the time. As many of you know, I'm sorry, I have to use my cheat notes. Dr. Leykum is the Associate Dean for Clinical Affairs here at the Health Science Center. She's also our Division Chief of the Hospital Medicine Service, who we rely on extensively now with transplant medicine. Today she's going to talk to us about a subject that's all near and dear to our heart, and the Affordable Care Act. Without further ado, I was going to hear no cheers occurred, so I'm a supporter of the Affordable Care Act, just so you guys know.
Okay.
So. Okay.
I'll use one.
And the guys that talk.
Yeah.
I'm going to turn this off.
All right, well, thank you. The lights will go out? Yeah. Okay, so thanks for having me back. It's nice to see you all. I'm going to talk about the Affordable Care Act, and I will I have a disclosure to give that I'm on the question writing committee for hospital medicine for the ABIM. I have to put the slide in all my presentations. And I want to start out by asking you, what's your familiarity with the ACA? So how many of you aren't sure what it is? Okay, nobody. That's good. How many of you have read about it in the paper? Okay, a few of you. How many of you know what it is but have no idea what it means for you? Okay. And how many of you have actually read the legislation? No. I like that. Nor has Congress. Okay. All right. So here's our objectives for today. We're going to identify some key contextual factors for the ACA, because I do think it's really important to understand the legislation. You have to put it in the context of what people think about healthcare and also the political context. We'll talk about some key provisions, talk about where the ACA is now with regard to implementation, and talk about impact on physicians. There are a lot of politics with the ACA, and the ACA kind of intersects a lot with people's political beliefs, so I really try and keep that out of the presentation, but if I fail to do so in some way, I'll apologize in advance. We're also going to have a geography lesson today, because you're going to see like a dozen maps of the United States in this presentation. So we'll start with talking about what issues the ACA is trying to address. And one key one really is quality and cost. So there's, I think, a lot of concerns about the cost of healthcare, and then not just the cost, but then what are we getting for what we're paying. So this is a pie chart of the federal budget, and then you can see Medicare and Medicaid together over 20% of the federal budget. Again, that's, a lot of money. Medicare alone, almost $500 billion. And then when we think about the quality, what we're getting for what we spend, I'm sure you all have heard these statistics in terms of what we pay relative to other developed nations for healthcare, and then what our general markers of health are in relation to those other countries. So the US spends 2 to 3 times as much per capita as any other developed nation on healthcare. Most other countries are in the $2,000 to $3,000 range. We're upwards of $6,000 to $7,000. And when you look at just sort of gross markers of health, such as life expectancy, infant mortality, we don't do as well, or close to as well as the rest of the world. And another concern really is the variability. So there's a lot of variability in health outcomes from state to state. And this is just one map that shows which states tend to have the lower outcomes. So sort of this area in here, where we are, unfortunately. And there's a lot of variability also in what's paid on the state level. So for example, Colorado spends more than other developed nations on healthcare. Colorado spends less than any other state in the US, but still more than any other developed nation. And health outcomes are not necessarily related with what people spend. In fact, when you look at what states have the best health outcomes, it tracks very well with per capita income. And states with the highest income, Hawaii, Connecticut, for example, have better health outcomes than other developed nations. So it's really a complex picture. Access to care is another area that's been a concern, both in terms of variability and in terms of people having access. So 30% of low-income US adults report having financial barriers to care. And low-income US adults are also more likely to wait for care, sometimes 6 times as long to wait for care. So that's kind of the backdrop in terms of the perception of healthcare. People are asking, what's the value of what we're getting? How can we improve outcomes? And how can we improve access? So those are 3 really important questions to think about the ACA in the context of. And then the other thing is that, really the ACA is a product of negotiation and compromise in a political system. So when you think about some of the various stakeholders, in the year the ACA was passed, payers spent over $150 million in federal lobbying. Hospitals spent over $100 million. Right? So there's a lot of money in lobbying as part of this process. Patients and providers tend to have a much less organized voice in this process. And the political climate is pretty fractious. So you have on either end of the spectrum, on the far left, people that want a single payer system, Medicare for everyone. And on the far right, you have people that really want a competitive market system where everybody gets a voucher and people can make their own choices about healthcare. So again, when you think about the ACA, you've got to put it into this context of, why did we get the legislation we did? That's part of the backdrop. So I'm going to start with the question to illustrate some of the political aspects. So who called the ACA a criminal act toward young men and women? Who thinks Rick Scott? Rick Perry? Rick Santorum? Terry Branstad. I couldn't find another Rick in politics. So it's actually Rick Perry. Access to care. So another question. Which state has the greatest number of uninsured non-elderly adults? Texas. That is true. That is true. We have the largest number. So over 16%. And ours is actually over 20%. So when we think about improving access to care, we have to understand, well, who was uncovered prior to the ACA? And there's a few big groups out there. One is people that were working but had opted out of employer-based insurance. Another group was people that were working but didn't have an employer-based option. Then there were people who are not working, so again, don't have an employer-based option because they're not working. People with pre-existing conditions, and then people who are not documented in the United States. Okay? So we'll see how the ACA approaches all of these various groups. And really, the general approach in the ACA of expanding access is through expanding insurance coverage, okay? So we could, really discuss whether or not that's the best, approach or the pros and cons of that approach to trying to ensure access for everyone, but it's an indirect pathway. So it's if everybody has insurance, then everybody would be able to have access to healthcare. So the ACA has several provisions, and we'll talk about them in terms of how to get access for those different groups. So there's a bit about marketplaces. We'll talk about direct enrollment, that people can get health insurance directly rather than going through employers. People staying on their parents' plan, expanding employer-based options, and then Medicaid expansion. So let's start with, the backdrop for the access discussion, of course, is the individual mandate. And there's now a mandate that all individuals must obtain what's defined as qualified insurance. And for all of you working on your taxes for last year, you know now that you have to start declaring whether or not you have health insurance with your tax filings. Now, there are subsidies. So people with an income between 100 and 400% of the federal poverty line can qualify for subsidies, but it's after they purchase a plan. This is we'll talk as we go through about provisions that were sort of legally in dispute and went up before the Supreme Court, and this was one of them. And so when the law was passed, the idea was that Congress, the federal government, had the right to regulate health care as part of its jurisdiction over interstate commerce. That's something that the federal government has a right to regulate. And the idea was that if I, as a citizen of Texas, go to Louisiana, get into a car accident, and I'm uninsured, then I'm placing undue burden on the citizens of Louisiana, and that's not fair to them. Well, the Supreme Court did uphold this provision, but not for that reason. They upheld it saying, well, you're effectively treating it like a tax. In fact, you're making people declare it as part of their tax filings. And Congress does have the right to levy taxes, so it is in fact a constitutionally appropriate. There's also an employer mandate. So employers with 50 or more employees have to provide health insurance, or they start paying a $2,000 per employee penalty. And this is for employees who work more than 30 hours a week. There's also a small business marketplace that's created to help try and facilitate employers having access to being able to offer health care. This is also monitored through tax filings, and this has been delayed through 2016. So the individual is moving forward, but the employer has been held up. Okay. Now, there was actually a House bill that was passed last month that would increase the threshold for employers to provide coverage only for employees who work 40 hours or more a week. I don't think anybody thinks that this will continue to move forward, and Obama has said that he would veto this. And it doesn't seem like there's enough votes to override a veto. But you can see that these issues are still kind of really active in the political system. And one of the concerns about this is that because of this penalty, that employers might have incentive to not hire employees or to hire employees that work less than 30 hours a week. So now that we have this mandate, what are the mechanisms through which people can get coverage? So the first is the health insurance exchanges. So the idea here is that this is kind of, supposed to be kind of like getting car insurance. You decide what kind of coverage you want, what benefits you want. You can go to a website, see what the different premiums are, different coverage possibilities, and make a decision. That's all it's meant to be. And when this was set up, it was set up that the states could set these up, and if they didn't, there would be a federal fallback option. And also the idea was that this could be a solution for many people who are uninsured, that they could go to the marketplace, larger groups of people coming into the system and kind of pool some of their risk. So you might remember in an earlier slide, I mentioned that people had to get qualified plans. So here's some of the rules around what those qualified products are. Now, you all might remember at the time the legislation was passed, there was a lot of discussion of if you like your health insurance, you can keep it. Nobody's going to lose their health insurance. And then a whole bunch of people did lose their health insurance. And the reason was that they were on plans that didn't actually meet these minimum requirements to be qualified, so that the payers stopped offering the plans. Now, the federal government went back and said, well, okay, we're actually going to grandfather some of those plans and give payers some time to bring them up to qualified standards. But still, a lot of payers just discontinued the plans because they weren't going to be something that could be offered in the long term. So, people did lose their coverage. Now, they could pick up other coverage through the exchanges, but they couldn't stay on the plan that they had. So here's another map of the United States, and this shows what states have set up a state-run marketplace, so it's these darker blue states. And then what states defaulted to the federal marketplace, which is the orange states, and then there are some states in between. Yeah.
Because I know it's a charged topic for a lot of people that I lost my plan.
Yeah.
Is it a penalty that the insurance company would get if they continued that non-qualified plan? Who was going to get impacted by not having a qualified plan?
So a few things. One, technically, people wouldn't be able to say that they're meeting the individual mandate with those kinds of plans because they weren't qualified until the grandfathering came in. The other issue for the payers is they weren't meeting these minimum provisions for coverage, right? And so here's some of them. So, you've heard of the platinum plans, and this covers 60 to 90% of costs. So some of those plans might not have even covered this percent of costs. They might have excluded pre-existing conditions. So to get them up to this standard, patients would have had to pay different premiums, or the payers would have lost money. So that's part of why they got discontinued. Okay. So someone was going to pay more for these plans, basically. Does that make sense? Okay. All right, so what's the status of the exchanges? Well, the first enrollment period was last year. We're in the end of the second enrollment period. And 8 million people enrolled in the first period. A third of these were young adults. Now, that young adult number is actually really important. Because remember, when you're trying to do things like get rid of exclusions for pre-existing conditions and get rid of limits on the total amount of money that people can pay for, as part of their copayment, that makes the payers nervous, right? Because you can potentially be bringing a whole lot of sick people into the system. So from the payer perspective, they want a whole bunch of well people to come into the system as well, right? So that risk for costs can be spread over a larger pool, at least some of which are healthy, right? So that's part of why we ended up with this mandate to begin with, to try and bring everybody into the system, not just sick people. Okay, so everybody was really watching, well, who's going to sign up for the plans? And in fact, it looked like at least some young adults did, which is the demographic, the payers want. Another question is, well, what happens with premiums? Were the premiums going to be high? Well, in this first year, premiums were 16% lower than people who already had employer-based plans were paying. So it didn't look like they were prohibitively expensive. 85% of the people who signed up were eligible for premium subsidies, meaning they were within that 100 or so and 400% of the federal poverty line. So that's, the hopeful interpretation of that is, okay, well, we're bringing in people who might not have been able to afford it otherwise, and we're helping them to get insurance. So, another question with this is, all right, well, people can sign up, but do they actually keep the plan? So one of the things that you watch is, well, how many of those people are actually still paying their premiums several months in? And in fact, several months in, about 80% of them, 80 to 90%, were still paying their premiums, which again was viewed as kind of a good sign. Now, in terms of the second enrollment period, which we're in now, the projections for those numbers were 9 to 13 million more adults coming in. And it looks like, based on what I'm reading, that at least the 9 million target is set to be met for new additional people coming in through the exchanges. Now that we're in year 2, looking at the premiums again is something to do, because for that first year, the payers didn't really know, and when I say payers, I just mean insurance companies, they didn't really know who was going to come in, so they were making some estimates on what they would charge for premiums. But now, year 2, they have some information, so what's happening with premiums? Well, overall, nationally, they went up by 5.4%. But you can see, again, that those national numbers mask a lot of variability. So you have some states where premiums didn't really go up at all, and then you have some states where they went up over 15%. So there's a big mix in there. The other thing, and this is part of the legislation that I think people didn't pay a whole lot of attention to, but the payers got a bit of a hold harmless for 2 years in the legislation. So if their incremental costs were much higher than expected, the federal government would provide some support for that. So that will go away after this year as the legislation is currently written. So I think the interesting year to watch with regard to premium changes will actually be next year, because that's the year where the payers really need to get it right, because that backup option will go away. Okay. So we're going to transition to Medicaid, because that's another big strategy in the ACA for getting people health insurance. So what states spend the most money on Medicaid? Alabama, Arkansas, Mississippi, California, New York, Texas, Massachusetts, Pennsylvania, Ohio, Florida, Michigan, and Illinois. 2, yeah, okay, so you guys probably saw California and New York and knew that was going to be the right answer. So these 2 states spend between $50 and $55 billion on Medicaid. Now remember, Medicaid is a shared program between the states and the federal government. there's a minimum requirement that states have to provide to get federal matching dollars. And those minimum requirements are generally around children under 5, pregnant women, and adults with disabilities and low income. So Texas is one of the states that provides the minimum required to get federal matching dollars. Does anybody know how much Texas actually spends on Medicaid? Okay, $28 billion. Texas actually is in the top 5 in terms of what we spend on Medicaid already, even providing the minimum requirements, which I actually didn't know till I was preparing this talk. So we actually already spend a lot of money. So when you think about Medicaid expansion, and as we'll talk about it, the possibility of bringing a lot more people into that system, in the state of Texas, there is, a lot of potential increased cost. Okay. So the idea behind Medicaid expansion is that all states would expand Medicaid for adults with incomes up to 138% of the federal poverty line. And this is the federal poverty line. And the idea was that so for some states, that would be a huge increase. So like for Texas, it would probably more than double what we already currently pay for Medicaid. So the idea was that the federal government would support that incremental difference that states would have to pay. And they'd support 100% of it through 2016, and then they'd support 90% of it through 2020, and then the legislation is silent after that. Okay. So a lot of states were concerned by this because they said, okay, well, even if the federal government is paying 90% of that, that 10% is still potentially a lot of exposure. And then what happens after that? In terms of what the states sort of say in terms of concerns with Medicaid expansion, increased cost and uncertainties around increased cost are definitely high on that list. Now, this was the second part of the ACA that went to the Supreme Court, and a number of states sued, saying that this aspect of the law was coercive. And because the way the law was written was that if you didn't expand Medicaid to this point, you would actually not get federal matching dollars, and you'd effectively opt out of Medicaid. States actually have the option to opt out of Medicaid, even though none do right now. So that provision was, in fact, struck down by the Supreme Court. They agreed that it was coercive. So if you look at who's currently expanded Medicaid, and in fact, Indiana here is one that's in light blue, but they, in fact, did expand Medicaid about 2.5 weeks ago. So the green states have expanded, and in fact, a lot of these states already were providing that level of Medicaid coverage anyway. Orange states have not. The states that are pretty interesting to look at are the ones in blue. And some of these are Republican states, and Michigan, I think, is particularly illustrative because they were one of those states that said there's no way we're expanding Medicaid to start. Well, when you look at some of the economics around Medicaid expansion, there's a lot of reasons that it does make sense in terms of bringing in federal dollars. And when you look at on the state level who lobbies for Medicaid expansion, everybody does. So payers want Medicaid expansion, in part because there's managed Medicaid, just like there's managed Medicare, and that's business that they can get into. Hospitals want Medicaid expansion because they'd rather have Medicaid rates than nothing. Physicians as a group tend to be in favor of Medicaid expansion. That doesn't mean that most physicians accept Medicaid patients, but politically they tend to be in favor. So the TMA and the BCMS, for example, here in Texas, have come out in favor of Medicaid expansion. And then when you look right now for states that haven't expanded Medicaid, they're effectively net exporters of healthcare to other states because we all pay taxes that go to the federal government that then support healthcare in other states. So there's a lot of economic arguments in favor. So when you look at what Michigan did, they said, okay, we're going to expand Medicaid, but we're only going to do it for 3 years. That's all we'll commit to. So taking them through the period of 100% federal matching. And they said we're only going to expand through managed Medicaid, not fee-for-service Medicaid. So that allows them to kind of define, potential costs up front by saying how much they're going to pay per person who's on Medicaid. And all of the states that have done these alternative to the traditional expansion options have had some patient responsibility, i.e. financial copayment component. All those dark blue ones have. So that's what looks different for Medicaid expansion in those states. Okay? So, we'll see what happens in these other states over time. Okay, so these are the ones I just mentioned. Actually, New Hampshire is, okay, I'm gonna admit I'm confusing New Hampshire and Vermont. One of them is actually opting out of all insurance, and they're going to offer statewide insurance for everyone. So kind of like Medicare for everyone, but at the state level. So it'll be very interesting to see what happens with that state as well. So where does that leave us? So in terms of, since the ACA was passed, 8 million people have entered through the exchanges. About 5 million obtained coverage directly from insurers. So these were people that just went, either got insurance through employer-based plans that they just didn't get before, or went directly and got insurance not through an exchange. 1 million young adults stayed on their parents' plan, because now you can stay on until age 26. And 6 million people in the states that expanded Medicaid went on Medicaid. So the national rate of uninsurance has gone from 18% down to 13.4%. And then that'll go down farther as some of these other states come up with these sort of novel ways of introducing Medicaid, and as we see these additional waves of people coming in through the exchanges. Okay. So who's not covered currently, or who is uncoverable currently? People who are undocumented. So the legislation is silent on that group. There's no provision for that group. And then people who are Medicaid eligible in states that didn't expand Medicaid, right? So there's really no option for them right now. They could get insurance through the exchange. However, the laws were written very specifically. So you can only get a subsidy for getting health insurance through the exchange if you're between 100 and 400% of the federal poverty line. You're not eligible for a subsidy if you're below that, because the presumption was you wouldn't need a subsidy because you'd be eligible for Medicaid. Okay. So when you look at who's currently uninsured in the US, 25% of the people that are currently uninsured are actually Medicaid eligible and live in states that have expanded Medicaid. So, presumably these people should just go on Medicaid. 40% of those people would be Medicaid eligible but live in states that haven't expanded Medicaid. So this is Texas, for example. Just under 30% are in this level where they'd be eligible for subsidies on the exchange. And so we'll see what this number does, after the second enrollment period closes. But presumably this number should go down pretty considerably. And then people whose family income is at more than 400% of the federal poverty line, very few of those people don't have insurance in the US. Now let's look specifically at Texas. So there are 6.2 million people who are not elderly, Texans who are non-insured. 20% of those are just not eligible because of their immigration status. There's actually a 14% children and adults who are eligible for Medicaid and for whatever reason are not on it. 21% are people who would not be eligible for subsidies but presumably should be able to go into an exchange and get a product. Another, about 30% should be able to go into the exchange and get a subsidy. And then we've got 17% who are in that coverage gap of, again, being Medicaid eligible but without Medicaid expansion. So there's a lot of remaining questions with regard to expanding access through expanding insurance. And the first is, will people continue to sign up for plans through the exchanges? Year 2, it looks like the answer is still yes. But again, we'll see what happens with people paying their premiums and what happens with premium rates next year. What will happen with out-of-pocket costs? So this is a big issue. So y'all might remember before the housing crisis, the number one reason for personal bankruptcy in the US was because of healthcare costs. And most people applying for bankruptcy actually had health insurance. So the concern is when you look at some of these, bronze plans that only pay, or silver plans that only pay 60 to 70% of healthcare costs, for someone that has a lot of healthcare costs, that could still be a lot of money. And in fact, one reason for concern is when you look at who should sign up for that kind of plan, that's basically like catastrophic coverage type stuff. So that should be a young single person who doesn't have medical problems, who really just wants the lowest premium possible. But when you look at who's actually signing up for that plan, a lot of like families are signing up for those types of plans. So there is concern that those plans will not be adequate to cover people's healthcare costs over time. You know, we'll just have to wait and see on that. And then this is the big question: will insurance really enable access? So when you look at what happened in Massachusetts, when they expanded health, Massachusetts is very useful to look at, because a lot of what the ACA does was modeled on what Massachusetts did. And in fact, so they got their uninsured rate to below 4% after they expanded insurance. The uninsured rate in Massachusetts right now is almost only 1%. It's very low. However, waits for primary care are substantial in Massachusetts. So, you know, average waits are 40 to 50 days for general internists or family medicine providers. But again, there's a lot of variability. If you live in Boston, you're going to be waiting 3 or 4 months. So, you know, in areas of the US that are underserved, it's not clear that those patients will functionally have access to care even if they have insurance. So, which state has the greatest physician shortage? It's actually not Massachusetts. So it's Mississippi. So, you know, sometimes in Texas we just need to say, thank goodness for Alabama and Mississippi, because Mississippi is the lowest. They have fewer than 60 physicians per 100,000 population. We have about 65. Massachusetts actually has the highest in the country. They have over 300 per 100,000 people. So if they're having problems with their insured population, you can bet that other areas of the country are going to have problems. Okay, so that's it on kind of the access to care issue. So we're going to move now on to delivery system and reimbursement innovation, because this is another big part of the ACA. And in some ways, the all-in transplant are kind of already doing what a lot of this reimbursement reform is doing for everyone else. So the idea behind this is that changing the reimbursement system will change the way we deliver care. So if we change how we pay for care, we will drive changes in how care is delivered, we'll drive changes in provider behavior. And generally speaking, these are moves away from transactional payments, so less fee-for-service and more payments based on quality or outcomes, and much more capitation. So for providers, that means that we have much more financial risk based on how we do taking care of patients. So there's a lot of different things in the ACA. One is kind of funding mechanisms. So this is the Center for Medicare and Medicaid Innovation. They can fund new delivery system pilots. So basically, you know, you can propose something to Medicare. An example is the hospital medicine group at University of Chicago proposed an extensivist model to Medicare. And they said, we're going to take our patients that are always in the hospital and actually just get hospitalists to take care of them at home. We'll go see them in their home, we'll adjust their Lasix, we'll do their paracentesis, we'll just keep them out of the hospital by going to them. That was funded, and that was apparently successful because Medicare is still funding it. PCORI is another example of doing comparative effectiveness research to try and get at what are more effective models of care delivery, what are more effective therapies. Then there are a bunch of pilot programs that we'll talk a little bit about. Bundled payments, which you guys know already. Independence at home and value-based purchasing, and then of course accountable care organizations. So in what states were bundled payments first used? Anybody know who this is? Oh, sorry, that's Dr. DeBakey.
No, that's Cooley.
Oh, Cooley, sorry. I guess same group. So, oh yeah, okay. Usually somebody knows them. So Texas was the first state to have bundled payments, and it was around cabbages in Houston. So a lot of people have heard of Geisinger's program. They were kind of the first to get a lot of national recognition, but the first ones were actually here in Texas. So bundling is when there's one payment made for an entire episode of care, and all the providers and facilities have to figure out how to divvy up the payments between them. So the general approach here is, rather than paying, say, $11,000 for a combination of hospital anesthesiologist, orthopedic surgeon, hospitalist, physical therapist, Medicare says, you know what, we'll pay you $10,000 instead, so we'll pay you a little less than our cost would be otherwise. But if it costs you less than that to deliver the care, the difference is yours. So the idea here, so this is a reimbursement methodology, but what it functionally does is it really forces providers or parts of the system that don't normally talk to each other to start talking to each other and figure out, okay, well, how are we going to deliver care? What are our expectations? What physician preference devices are we going to use? What are our expectations for what drugs we're going to use? What antibiotics? What DVT prophylaxis? When are we going to get PT in to see the patient? All of those things, then there's discussions about them, and they're more standardized. So costs come out of the system. So Medicare had done a pilot, and you guys might have read about this because Baptist was one of the participants. There were 4 health systems in the country that participated. And the pilots were all around surgical interventions, so hips, knees, and cardiac cath and pacemakers. And it's not an accident that those were chosen, because a lot of the cost for procedures really are around the physician preference items. So what implant we use, what stent we use. So if physicians agree to only use 2 or 3 different devices rather than 10, you're getting more volume, you can get more aggressive pricing, and you can bring down the costs. And in fact, for 3 of the participants in the initial bundling projects, when you look at their costs in the base year and then subsequent years, they went down. And a lot of that decrease was really just in the physician preference items. So then the question remains, all right, well, what about other diagnoses, particularly the medical diagnoses? So right now there's a larger pilot underway, the Bundled Payments for Care initiative. This was started in 2013, and by started, that means that Medicare put out an RFA. People could make proposals, and then Medicare decided whether or not to accept them. And there were 4 types. And again, this is all around, hospital care. So Medicare generally spends more money in the hospital setting than anywhere else. So it's no surprise, and post-acute care is next. So no surprise that that's what it chose, and this is the distribution of places that are participating in this. So this is the first year that this has started. We don't have any data from it yet, so we'll see whether when you expand this type of program, costs will come down, and again, I think a big question is whether they'll come down for medical diagnoses as well as surgical. Independence at Home is a pilot taking 10,000 chronically ill elderly patients, and rather than putting them in nursing homes, pay for the care that would enable them to stay at home and see if costs are less and patient outcomes are better over the long term. There's a lot of data to suggest that older cognitively impaired people do better in their home environment. So, they're going to try keeping them there and see what happens. So this also, there's not really any data on yet. It's still in progress. Value-based purchasing. Who's heard of value-based purchasing? Anyone? Okay, so value-based purchasing is already implemented, and it impacts every hospital. So the idea behind this was that when this was getting started back in 2009, 2010, 7 million Medicare beneficiaries were hospitalized, 12.4 million times. Medicare spent $26 billion on readmissions and $4.4 billion on harm in the hospital. So they said, okay, we feel like we're paying for a lot of low quality outcomes, so we're gonna adjust payments to hospitals based on quality. So that's value-based purchasing. So they use these metrics, and I'll tell you what they are, to adjust hospital reimbursements up or down. So in the first year, they had a separate pot of money that they used to make these payments. And in the second year, and what's currently still going on, is that they reduce hospital reimbursement for all DRGs, all discharges, by 1.25%. And that creates the pot of money that's then the incentive pool for value-based purchasing. And here's Kathleen Sebelius, again, talking about if we pay people differently, care will be delivered differently. So here's the methodology. There's process measures of care, and these are pretty standard core measures. Patient experience. How many of you have heard of HCAHPS? Okay, the Hospital Consumer Assessment of the Healthcare Provider System. That's 30% of the measurement. And now mortality measurements, this started 2014, 25%. Now this, of course, is risk-adjusted mortality. So when you see more and more documentation improvement folks in the hospital talking to us about what our documentation is, this is why, because the risk adjustment is based on what we write in the chart. Okay, so here's some HCAP questions. Did your doctors treat you with courtesy and respect? Did they listen to you? Did they explain things to you in a way you could understand? There's a lot of questions. Some of the questions are about kind of the physical plant. Were you in a quiet environment? So I don't know if you all remember before Sky Tower opened, that elevator bank between Rio and what are now Rio and Horizon, like they stopped using that at night. This was part of the reason, right, to create a quieter environment because they were getting a lot of negative responses on that question. Now, this is something of concern generally to academic medical centers because they tend to be under-resourced. Patients generally tend to have lower experience scores. There's just more people coming in and out of the room. Patients don't always understand who they are, et cetera. So and in fact, if you do look, academic medical centers tend to have lower scores on this. So that's, a concern. So here's the methodology. They basically compare you to yourself, to your historical performance. So they'll either look at how good your scores are in an absolute way, or how good your scores are compared to how you used to do. And they'll take whichever was better. And that's always one of the quandaries with paying for performance. If you pay for attainment only, performers down here will say we have no incentive to improve on that metric because we'll never get there. Right? But if you pay only for improvement, high attainers will say that's not fair because we're already up here, there's nowhere for us to go. So they look at both and see whichever you do better. So in the first year of value-based purchasing, UHS's reimbursement for Medicare was $220,000 lower than it had been previously because they basically didn't get any incentive metrics. Last year, it was $180,000 lower. So, we've got some work to do there. So that's value-based purchasing. I'll mention accountable care organizations, again, because these are kind of in the news, and it's a big part of the legislation. But this is just another, again, a different reimbursement methodology. And in some ways, it kind of picks up on elements that are in bundling or in value-based purchasing. So the idea behind an accountable health care organization is that it's a group of providers that is responsible for all of the care of the patient for a certain amount of time. That's all it is, right? Now, of course, with all of these things, there's the theory and then there's the, well, how is it actually implemented? But it's all of the care, outpatient, inpatient, post-acute, skilled nursing, home health, pharmacy. So there's two ways that ACOs come in. There was the Pioneer Program, which is the first group of 32 organizations that said, we want to try this. And the second place, there's a pediatric one, and then there's a Medicare Shared Savings Program. And the idea behind actually all of these to start is Medicare looks at the total costs of patients year over year. If it costs your accountable care organization less to take care of patients in year 2 than it did in year 1, you get a share of some of that savings. That's the idea. And then over time, you can opt to move to just getting capitated payments, where you just get a fixed amount of money to take care of a patient for a year. Does that make sense? Okay. So again, there's performance risk here for providers, particularly when you move to a capitated model. Because if it costs you more than that to provide care, that's kind of too bad. Like there's no other money coming. So here's just the trend in the number of ACOs. So there's over 600. And when you think about who can form an ACO, what do you need? You have to have a lot of patients because you have to be able to spread risk over a big population. The way Medicare defines it, you only need 5,000 patients to apply to be an ACO. The way Aetna would define this, they'd say you need 250,000 patients to really be able to manage risk over a population, right? You need to have, so to get a big population base, you're gonna need geographic spread. You're gonna need to be a certain size, You're also going to need kind of vertical integration, right? Because you're responsible for all the care that's delivered. So when you see this trend in healthcare towards bigger and bigger consolidated systems, this is part of why, because you really need that to be successful in these reimbursement methodologies. You also need to have data. You have to understand your practice patterns and understand where you need to improve. So who has the capability of doing that in the current system? Well, there's three options. There's big provider groups, there's hospital systems, and there's payers. Those are the three entities that kind of meet those requirements potentially. And you can see who's actually setting them up. So, there was I think physicians still have a lot of concern that they're sort of somehow getting left out in these big healthcare organizations. But in fact, more than any other group, these are getting started by multi-specialty physician groups. Hospital systems are the next. And then insurers are way down. Here's where they are. And so you see this map does not look like the other maps, right? There's no red or blue state here. They're everywhere. Okay, so we kind of talked about what the shared savings looks like. But again, any decrease in cost between what Medicare used to pay and what they pay now is potentially shared. And there are different options for the amount of risk you're willing to take, whether you're willing to meet upside or down, whether you're willing to take downside risk or not. But that's the basic idea. So how have they done? Well, if you look at the 32 original ACOs, 19 dropped out of the program after 2 years. 9 exited the program after the first year, and mostly because they didn't decrease spending. Now, when you look at what happened from an organizational level, the range was -7, so some did well, to +5 in the first year, and then -5 to about +5 in the second year. And to me, I interpret this as this sounds good, but this is really hard, right? It's really hard to know what your costs are, to understand your processes of care, to really figure out how to take care of populations of patients, right? Here were 32 organizations that thought that they could do it, and more than 50% found that they could not. Not to say it's undoable, but you can see when we talk about shifting risk to providers, it's not something to undertake lightly. So 11 have shared in savings, 3 have shared in losses, and 3 are still getting reconciled. Now, I got these data from the Medicare website. I know they don't add up. Okay, say that now. So, but Medicare says that through the organizations that have stayed in the program, they've saved $96 million total. They paid out $68 million, so that the net positive impact is $41 million. That minus that is not that, but. And when you look at overall at the per capita spending growth for this group of organizations, the increase was 1.4%. So you might say, well, it's still going up, except it's going up much less than for regular fee-for-service Medicare. So Medicare views this as a win. Any ACO has to report quality scores, so they've done that, and it looks okay. All right, I'm going to skip through that slide, because again, it's kind of a similar theme with the shared savings program. So just kind of to finish up, we'll talk about where we are now with ACA implementation. So we talked about access to care, the individual mandate, insurance exchanges, Medicaid expansion. Then we talked about these different reimbursement methodologies. So where are we with the implementation overall? So how many states have sued the federal government over the ACA? Who thinks 16? 28? 37? So the red states have all sued the federal government. It's amazing, isn't it? So there have been a number of issues with implementation. The first, and these get a lot of press, right? So you've probably heard of them. There were issues with the website. This is a big issue, this funds appropriated for implementation. And we'll talk about this with some of the legal stuff. But the idea is, again, when you look at who has the power to do what in the federal government, Congress has the power of appropriation. They're not currently appropriating more funds for the ACA. It's getting basically, a lot of it's getting funneled through HHS, Health and Human Services, or through the IRS, right? Because a lot of this is being administered through the IRS. So there are many people in Congress now saying, well, we didn't specifically say that money allocated for HHS or for the IRS could be spent in this way. Therefore, those entities cannot spend the money in this way. So we'll see. Lots of logistics with the IRS. You know, there's a lot of people that don't pay taxes in this country. It's not clear how what you check off on your return could really be verified, how that process is going to work. A lot of details still unknown with that. And then the legal challenges. So we talked about the mandate. That was upheld. Medicaid expansion was not upheld. This is the third one. Subsidies for federal exchange enrollees. So we talked about if you're between 1% and 400% of the federal poverty line, you'd be eligible for a subsidy through the exchanges. However, the law specifies only people who enroll through their state exchange. So the challenge here is whether people who get their insurance through a federal exchange, because their state did not set up an exchange, would those people be eligible for a subsidy? So the Supreme Court has agreed to hear this. We'll see what they say. You know, honestly, again, this is just sort of based on my reading of people writing about this, but it seems like the law said state exchanges, so there's this feeling the Supreme Court's not going to have a lot of latitude to say other than this is what the law says. But we'll see. And then we talked about this issue of appropriation. And this hasn't really come up as a specific legal challenge yet. We'll see if it does, just because there's a lot of the issues being raised. Some elements of the ACA have been delayed. So the out-of-pocket spending caps were delayed till this year. We talked about the individual mandate being enacted, but some of the employer mandates being delayed. So they overall were delayed until 2015. And then for the smaller employers of 50 to 99, that's been delayed till next year. And then the plan compliance, right, for those grandfathered plans, you know, initially they were supposed to become compliant by this year, but that's gotten pushed off to next year. There are also a few little snafus. So, and I kind of touched on this first one, people might have been eligible for Medicaid, but they're not eligible for a subsidy, because the subsidies are specific to 100 to 400% of the federal poverty line. And then this other thing is when you look at affordability, and whether you're eligible for a subsidy or whether your income, there actually is an ability to opt out of the mandate if your income is of a low enough level that your premiums would be more than 8% of your net income. Okay, they look at affordability based on individual premiums. So there are actually families for whom, as a family, something's not affordable, but as individuals it is. So you see circumstances where adults are getting their own individual insurance through the exchanges and the kids are going on Medicaid, and that's much cheaper than trying to get a plan as a family, which again just seems like, you know, it's certainly more work to do that. It's just one of the ways that this has worked out. So what does the future hold? Will it be repealed? So it's very interesting to look at how the ACA is talked about in the press, because the ACA as an entity is 60 to 70% of the time written about negatively. When you look at how most of the provisions are written about, they're actually written about positively. And in fact, if you ask most Americans what they think of people not being able to be denied insurance because of pre-existing conditions or young adults being able to stay on their parents' plans, most people are actually in favor of those things. So there's this notion that most people actually like a lot of these provisions, so they're not repealable practically. And also, when you look at all the people getting on through the exchanges and through Medicaid expansion, this may be almost 40 million people coming into the system within the next few years. Certainly by the time we could have a big change in the party of the president, right? Will this be repealable if there are almost 40 million people who have insurance who would not have insurance if the ACA is repealed? So most people seem to think that it's not functionally repealable. However, this issue of how the money is spent is a very real issue, I think. And then, will we see more cost controls? Will we see caps on subsidies, caps on Medicaid? I think probably yes. And again, where's the locus of control? The states or the federal government? More discussion about that, I'm sure. And the big question is, will costs go down? So these are the projections. So it looks like they're going up, but in terms of a percent of total federal outlay, right now, it's projected to sort of plateau out. And if you look at the rate of increase in spending, that's actually slowed down. So we'll see. And that's another one where payers and Medicare have all started to change how they pay for healthcare services. And even if the ACA were repealed, they're unlikely to not pay differently than than these new methodologies. So again, on a practical level, may not matter. When you look at Massachusetts, growth of healthcare expenses in Massachusetts, again, going down. So what does this mean for us? More accountability for us. We have to understand how we practice. And again, I mean, you guys already are paid under a bundled methodology. You're probably the most sort of integrated service that I think we have from the school's perspective. So you're kind of our models in how we do this. But aligning delivery and integrated system. You might not feel like you're the models of how to do this, but to us you are. We kind of talked about some of this vertical and horizontal integration. And this organizational and system effectiveness are going to be increasingly important. So thank you very much. Any questions, comments?
Somewhat unrelated, well, related but unrelated. What am I blanking on what it's called? CareLink.
CareLink, yes.
The rumor is CareLink's going away, and the county is basically pushing those eligible for CareLink to apply for a plan. Where at one time CareLink was touted as this, it was marketed to other cities and so forth. Why did that happen?
Okay, so Texas is pretty unique in that they basically push healthcare funding down to the county level, which is why you see things in Bexar County, Austin, Houston, and Dallas, and then really nothing in between. So CareLink is basically payment support, right? So people have to make some contribution to their healthcare costs, but CareLink pays the rest based on its defined benefits and its network. So there's a few issues. One is a fair number of people who are on CareLink are eligible for exchange products. So think about it from the perspective of the group to whom UHS is accountable. They are accountable to the taxpayers of Bexar County because it is our property taxes that support that entity. So they're looking at this and saying, well, should we continue to have support for these folks kind of funneled through property taxes, or should they get a product through the exchange? They would, depending on how that one thing with the state versus federal exchange works out, they could be eligible for subsidies, and then that's kind of shifting the cost burden elsewhere. So I think that's part of their calculation. The other sort of practical issue is there's a lot of people on CareLink who are not documented, and whether that's feasible to continue, I think, is another question. But again, the bigger issue is there are other options now besides CareLink. And the idea is we're going to help people to exercise those other options. I don't think CareLink's going to go away entirely. I mean, UHS is not saying that.
So you had mentioned this pending House or recently passed House bill. Is there any pending or current legislation actually looking at some sort of cost control? It seems like that's something that really got taken out of the affordable care.
So, not directly. So the cost control stuff is really kind of like access to care. It's kind of at arm's length, right? So they're not saying specifically cost controls, but they are giving the Center for Medicare and Medicaid Services the ability to change how they pay providers. And in fact, one of the things I didn't mention, but it used to be for Medicare and Medicaid to change how they pay providers, they had to do a pilot. They had to get it vetted by a third party, and they had to go back to Congress to approve expanding. That took, on average, 5 years. Now they don't have to go back to Congress to get approval for any reimbursement methodology that they deem successful. So this does give Medicare a lot of latitude to change how it pays for things.
Those would be done as research protocols, like that place you mentioned with.
Yeah, it's both actually. So some is through CMMI and through PCORI, and some is through these projects like the bundling projects, value-based purchasing has impacted everyone, ACOs. But Medicare has done other, the independence at home, the bundling. Medicare has done other pilots, such as they did a patient-centered medical home pilot looking at costs and outcomes, and that was viewed successfully. It started in a dozen programs. So they've changed the way that they're, so basically what happens is when these get started, organizations can apply to be paid that way. And then usually then Medicare will later say, okay, we're gonna start paying everybody this way. And in fact, there was a whole precursor to value-based purchasing with a voluntary program that, again, was viewed successfully. So they rolled it out to everybody.
So, when people approach me, because, you know, oh, you're a doctor, you must have some involvement in this affordable care thing. You know, one anecdotal story is my premium just went up $300 a month. How is that affordable? And I have no way to explain anything about what their premium was. So my understanding, my assumption is people who had pre-existing plans that apparently met the provisions to continue as a plan, but weren't necessarily one of these ACA plans. I don't know if this even makes sense, because my own
Okay.
plan, I have no idea.
Right.
But I know it's a very expensive plan. Is there any caps or rules that prevent the insurer from increasing those premiums so they can then fund these lower plans, or?
Yes and no. Okay, so now part of the way they're trying to get at this is by pushing everybody into the system, right? Pushing a lot of well people into the system. Because the idea is those people pay something and that brings costs down for everybody. There are limits to how much premiums can increase. And insurers aren't supposed to be able to exceed those increases. They're pretty high. The ones that have been challenged have been pretty high, like 20 to 30% premium increases. So you can still have a lot of increase and be legal from the ACA perspective. You know, for people that saw a big premium jump at the time of the ACA passage, those were really people who were on these plans that didn't meet minimum requirements, that then going to a plan that does, suddenly those plans are much more expensive. Other things that are happening, the ACA actually gives employers now the ability to stratify their premiums based on employees' health behaviors. So those of you who are employed by UT know that you have to now answer questions about smoking. Employers have taken this to, I mean, you can get a lower premium if you not only join a gym, but every month show how many times you went based on your swiping in. So there's premium stratification based on that as well. So there's a number of reasons why people's premiums might go up. When you look at healthcare cost increases relative to, you know, other things we pay for, like if the cost of your eggs went up as much as healthcare costs are, you'd be paying over $50 for a dozen eggs, right? The rate of healthcare cost increase has been very high. All right, yeah.
I'm concerned about the, obviously, it's wonderful that we have millions of Americans that now have access to care. I wonder the logistics of delivering that care. You highlighted the experience in Massachusetts, and I'm embracing myself, you know, for what's going to happen in Texas. Have they had any discussions about, you know, assistance with opening more clinics, maybe expanding the number of providers?
Yeah.
I can envision, you know, the patient's experience is going down as the waiting rooms are packed.
Mm-hmm.
As doctors have less time to spend with each individual, as the wait times to have a doctor's visit go up.
Mm-hmm.
And then, you know, I just wonder if any of the practices might look at as a disincentive to accept patients with these plans, and if there's going to be any cherry picking.
Yes.
Patients that are being put in the store. So I wonder on the logistics side, do you have any comment on these two questions?
Yeah, well, yeah, there's a few questions in there, and if anybody has to go, I won't be offended if you leave. But okay, so one question is, are these plans attractive to providers? The answer is generally no. So most of the rates that they pay, from a physician perspective, most of the rates they are offering to physicians are between Medicare and Medicaid rates, so below Medicare. And they have high deductibles, some in the $6,000 to $9,000 range. And so patients have to pay that much before their plan kicks in. So from the physician office perspective, you have got to know at any given time where they are with regard to paying that upfront cost before you can charge their insurance. So you have got to have, again, just from a revenue capture perspective, you're often then going to be in the situation of saying to a patient, okay, it's going to be $300 before we see you now, because you haven't met your $6,000 or $9,000 deductible yet. The bronze and silver plans have those kinds of deductibles. They're big. From a hospital perspective, they don't care as much, because remember, hospitalizations are expensive, so most people are going to meet their deductibles with the hospitalization. Okay, so that's one issue. So like our UT medicine practice is not, we're not taking any of these plans yet. I'm sure we will, but we're not yet. Okay, wait, there's, okay, yes, this is a big issue. And there's very little in the ACA about the workforce. There's almost nothing. So, a lot of this is regulated at the state level in terms of licensure and scope of practice. At this point, only 14 or 15 states do not have independent scope of practice for non-physician providers. Texas is still one of those states. So whether that starts to change more in states is a question. Now, when you look, a lot of the rationale for expanding scope of practice for non-physician providers has been based on expanding coverage or expanding access for people who live in underserved areas. When you look at where non-physician providers actually practice when they have independent prescribing authority or independent practice authority, they work in the same places as physicians, right? So that hasn't yet been an effective strategy for expanding access to underserved areas. But it's certainly a possibility. And I think all those things really are concerns, right? So whether insurance gives people true access to care is a real question. In a lot of the U.S., it functionally may not.
Thank you.
Okay.